So how does the first beta blocker or first generation beta blockers developed? So we first started with agonist. That means the drug that mainly binds to the adrenergic receptor, and then we first then tried to selective for beta receptors only. So then that means we chose those agonists. Those are capable of binding to the beta receptors, not to the alpha receptors. So the compound we chose as a lead was isoprenaline. So this structure mainly this has more selectivity towards beta receptors, and this is an agonist. So this is not an antagonist. So we started with an agonist. So this is an uh, active. This is active towards beta receptors. That means it is selective towards beta receptors over alpha receptors. The next, so then like this structure mainly shows the selectivity towards beta receptors. Then we try to edit or add or modify different groups to see how the selectivity mainly works, and then we mainly develop the antagonist from this agonistic activity. Like for example, replacing those phenyl groups with this chlorine group mainly produce this structure dichloroisoprenaline, and which is not fully agonist, which is partial agonist and partial antagonist. So this mainly helped like converting or substituting those phenyl groups with two fluoro groups, mainly converted the agonist to a partial agonist or partial antagonist. The next, then we added an extra aromatic ring here. Like it is a common approach to convert an agonist to antagonist is like adding different heterocyclic or aromatic groups. Then we added another group which mainly forms naphthalene group. So this double benzene is naphthalene. So this mainly produces a pronethalol. It is called pronethalol. So this drug mainly then it is used clinically to reduce the severity from angina and to reduce hypertension. So it is the first beta blocker, but although this is not fully antagonist, so it is also partial antagonist, but it has better activity than this dichloroisoprenaline. So the next we mainly developed the first successful full antagonist or pure antagonist, which is propanolol. So from this structure, like adding a ethyl group here and like this naphthalene group, and also like this R R enantiomer of that compound is converted, like this hydroxyl groups are positioned in different way, reverse way, so that the compound can become S enantiomer. So this propanolol is S structure, S enantiomer, and just one extra ethyl group is present. So this maybe is full antagonist, and it helped a lot in reducing the cardiac arrest or angina. So the discoverer is a Scottish scientist. Mainly, he got a Nobel Prize for this discovery of this propanolol beta blocker. So note that the first generations are non-selective beta blockers, which means it inhibits both two or three types of beta receptors, beta 1, beta 2, beta 3. So it comes with a lot of other problems, but mainly it reduced the primary problem, which is the hypertension and angina, but it comes with other problems. We'll be seeing that. So now we'll be seeing the SRs of the beta blockers, first generation, the propanolol, which is mainly derived from this aryl oxypropanolamine. So this is aryl group, and this is aryl oxy, and this is propanol, three carbons, 1, 2, 3, 3, and this is amine. So and rest of this is like the side chain. So this derivative propanol is mainly derivative of this structure. So as you can see, the propanolol is mainly this group of drugs, aryloxypropanolamine. So next the SSR. So the first SR is like this structure, isopropyl alcohol, like branching, like branched alkyl groups such as like different tertiary butyl or isopropyl alcohol. Those mainly helps for the activity. Those branching structures are helpful for the activity because if if you look at the structure of alpha receptor beta receptors, both the receptors are just similar in structure, but the beta receptor has just here, and this right side of the receptor has just one extra pocket. So here, if you add some groups, these branched groups will will interact with that extra hydrophobic group and fits those hydrophobic pockets. So one extra pocket is here in the beta receptor, and those mainly in those branched structure mainly increase the selectivity towards beta receptors by fitting towards this hydrophobic pocket more than the alpha receptors, because alpha receptors don't have here extra hydrophobic pocket interaction site. So this like this isopropyl or tertiary butyl groups are like optimum. That means you cannot increase the carbon size or chain size beyond that, but like longer than isopropyl or t-butyl will reduce the activity. However, there's like n aryl ethyl groups. So with different groups such as aryl ethyl groups, like this structure CH2 phenol and this like aryl group, or if we add aryl group and alkyl, so aryl ethyl groups will be beneficial. So this is like it is an extension approach. An approach contains an aryl group. So this is like an exception to the this optimum level of the T-butyl or branching. We have seen that we cannot use longer compounds than isopropyl T-butyl, but here if we use aryl groups and then side chain of ethyl, then this will be beneficial for the activity. So this extension strategy is helpful. So next, the amine group must be secondary. So here, the amine group should have two R groups attached to it. So it should have to be secondary amine group. The next, like this aromatic group, the naphthalene, we can change it to aromatic groups, different heteroaromatic group. So it is not must for the activity, but we can change it. Like other beta blockers such as pinodol, timodol, those mainly have this heteroaromatic structure here in the place of this naphthalene structure. Next, the methylene group in the side chain. So here is methylene group present, here CH2 is present. So if you substitute something here in the methylene group here, this will lower the activity, but this is helpful, like it will increase the plasma half-life, or it will prolong the activity through increasing the metabolic stability. So other drugs you can manipulate here. So it's, for example, if you want to uh, if you want to have longer effect with prolonged time, then you can edit methylene groups or substitute here. But this will lower the activity, but this will be helpful for a large doses, but this will require large doses and for the same activity, but this will stay in the blood for longer time of this metabolic stability. The next, so the alcohol group on the side chain, like this alcohol group, like all the other catecholamines, we have seen this alcohol group is a must for the activity of the hydrogen bonding to the receptor site. So this is like for agonist and antagonist both, this hydroxyl group is paramount. So here it is positioned in the S position, but this nonetheless R or S, this hydroxyl group is the must for um, main hydrogen bonding interaction to the adrenaline receptors. So the next, so this ethyl group is also involved in hydrogen bonding to the receptor. So this, if we can replace this ethyl group or oxygen here with sulfur or methylene, then this will create some level of toxicity detrimental to the tissue. However, like tissue-specific beta blocker has been developed by changing this oxygen with NH group. So tissue-specific means like if you want to develop beta 3, then we can change here, but in general this will detrimental to other tissues. So tissue specific means it will be helpful for some tissues. That means is it will not be toxic to some tissue, but it will create toxicity to the other tissue. So if you want to like develop in IV form or like site specific intramuscular to the local region, then we can use those tissue specific non-toxic agents or the beta blockers. So we can pump directly in the heart. So if that is not detrimental to the heart, but it is detrimental to the liver, then we cannot use in general, but we can locally inject in the blood, inject in the heart. So if that is not toxic to the heart, so that is tissue selective. That's how tissue selective beta blockers can be developed. So as you know that all the drugs from the first generation has some problems, shortcomings. The beta blockers also have first generation beta blockers also have shortcomings or limitations. So the main one is this bronchial constriction because the first generation is non-selective. That means it cannot differentiate between beta 1 or beta 2. So the propranolol mainly inhibits the beta 1 receptor in the heart and beta 2 in the lung. So in a normal case, this will not be a problem in a normal person. But if the person is an asthmatic or COPD patient, then this will create some serious level of problem in the lung because beta 2 receptors will be blocked in the lung, and this will create serious short of breathness and subsequently like asthmatic attack. So vaccinations also causes fatigue, tiredness to the limbs, also reduced cardiac output, and the first generation is highly lipophilic and crosses the blood-brain barrier and causes unwanted CNS effects, dizziness, nightmare, sedation, etc. So the second generation is a bit more water soluble and a bit less lipophilic, so they cannot cross the blood-brain barrier. So one other important is heart failure to the terminal patient. So if the patient is too much, like if their valve ventricle is too much hardened, like like when the heart cannot pump too much blood because the heart has lost most of its muscles because of like toxicity or deprivation of oxygen. So then the heart will try to increase its size. So at some point it cannot like hyperplasia and it becomes hardened. So at that point the propranolol cannot help further. So at that point to the terminal heart patients this will cause serious heart failure at some point suddenly. So this is one shortcoming of fascination beta blockers. So the other one is the inhibition of noradrenaline release at the synapse. So the noradrenaline are mainly released from the nerve signals, like the postsynaptic nerves. So like when all the organs are connected or innervated with the nervous system, peripheral nervous system. So noradrenaline are released from those nerves to the organ to send signals. So those like as at the end of the neuron, this postsynaptic synapse. So those are the region the noradrenaline are secreted or released, and those will be inhibited by this calcination developers. So the second generations mainly developed by overcoming those problems, not fully, but majority of the problems are resolved. So these are the second generation beta blockers as butolol, atenolol, metoprolol. All are S isoform or S enantiomer. So note that all the natural agonists are enantiomer. R enantiomer was more active in case of adrenaline, noradrenaline, but the drugs propranolol and the structure S enantiomer structure. That means this hydroxyl group is present here, not at the upper side. So one important difference from the first gen and the second gen is this structure. This here you can see this NH like this group at, at what position is this? Para position. Yes, para position is here. In the para position of the ring, this extra group is present in all the cases of the second generation drugs. So that is new from the first gen and the second gen. So this mainly helps in the more selectivity towards the beta 1 receptors. In other words, this extra groups at the para position mainly helps reducing the selectivity towards the beta 2 receptors and increase selectivity towards beta 1 receptors. So that though these agents will not cause problems in the lung or not cause problem in the asthmatic patients. And also, second generations are a bit more water soluble and less lipid soluble. So as a result, those will not penetrate the CNS and not cause some unwanted side effects of the CNS. So yes, water soluble beta blockers such as atenolol are less likely to enter the blood-brain barrier and less likely to cause unwanted CNS effects. So that are that's how mainly the second generations are more favorable in condition in clinical context and has more um, beneficial activity than the first generation beta blockers. So that's where the chapter ends. Thank you.